Hey everyone, my name is Eliza Roy-Webb. It's August 25th, 2020, and I'm doing the Unit 2 Case Connections. I'm going to be reviewing Case 3 and Case 4. Case 3, this 5-year-old patient is exhibiting classic symptoms of hyperglycemia, drowsiness, persistent thirst, and frequent urination. Reviewing the patient's serum insulin levels at baseline and 1 hour post-glucose load, insulin levels at both intervals are dramatically less than the control. This leads me to believe the appropriate diagnosis for this patient will be type 1 diabetes. Type 1 diabetes, although less common than type 2, is typically diagnosed in children and teens with a peak in presentation between the ages of 5 to 7. This disease is thought to be an autoimmune disorder where the body mistakenly attacks the beta cells of the pancreas, which is where insulin is created, destroying them and therefore producing little to no insulin. This results in a consistently elevated blood glucose level and can ultimately damage end organs. This patient's fasted blood glucose would therefore be elevated. Due to an inability of the body to use glucose as a means of energy production, other regulatory hormones will be increased, such as glucagon and cortisol. Hepatic gluconeogenesis and glycogenolysis occur because of the increase in glucagon, and glucose levels will increase in peripheral tissues due to the lack of circulated insulin. Two regulatory enzymes that will likely be active in this condition will be glucokinase and pyruvate kinase. Glucokinase, found in the liver, is activated when blood sugars levels are elevated. This enzyme removes glucose from the hepatic portal vein and regulates the amount of glucose available to peripheral tissues. It facilitates phosphorylation of glucose, creating glucose 6-phosphate, which then enters glycolysis to create ATP. Under normal conditions, the increase in ATP inhibits potassium channels of the cells and causes a calcium influx, stimulating release of insulin into the bloodstream. But without insulin, blood glucose levels will be elevated in the peripheral tissues, and untreated long-term effects will lead to end organ damage. Pyruvate kinase is a regulatory enzyme that will also be active in this condition. This enzyme catalyzes the reaction of phosphoenol pyruvate to pyruvate, which forms 2 ATP per molecule of glucose oxidized. Under anaerobic conditions, pyruvate is reduced to lactate. Under aerobic conditions, pyruvate is transported to the mitochondria and enters the citric acid cycle. Pyruvate could also be transaminated to alanine. Increased levels of ATP will reduce the activity of pyruvate kinase along with other regulatory enzymes of glycolysis. One topic I'd like to address is diabetic ketoacidosis, or DKA. This occurs when an individual remains in a state of hyperglycemia over a period of time. With activation of counter-regulatory hormones, lipolysis increases, which releases a large amount of glycerol and free fatty acids, or FFA, into circulation. Hepatic mitochondria oxidize the FFA, creating ketone bodies and leading to acidosis. And DKA can lead to death if untreated. And I do have a little diagram here of, so on one side, we're looking at relative insulin deficiency, and that's seen more with type 2 diabetes, and that can result in HHS, which is hyperglycemic hyperosmolar state. But right now we're focusing on type 1 diabetes, and that is the absolute insulin deficiency, or in this patient's case, very, very little insulin production. So here at the top, what happens is in diabetic patients, if stress, infection, or insufficient insulin intake, that'll result in an increase in glucagon and cortisol, like I mentioned, along with other regulatory hormones. This therefore leads to an increase in lipolysis and increases free fatty acids along with glycerol. And then in the liver, gluconeogenesis and glycogenolysis are activated, and then all of this ends in an increase in ketone bodies and you then lead to ketoacidosis. All right, and then case 4. This 2-year-old female presented to her practitioner with signs of having a metabolic issue, with her symptoms including jittery spells 2 hours postprandial, hepatomegaly, and hypoglycemia. This leads me to believe that the correct diagnosis for this patient would be glycogen storage disease, or GSD. GSD is a group of disorders that are characterized by the inability of the body to adequately store glycogen or storage of abnormal forms of glycogen. This ultimately leads to liver damage and muscle weakness, locations where glycogenesis mainly occur. This is caused by a mutation in specific genes related to the process of glycogenesis. The most common form of GSD is von Gierke disease, which is a deficiency in the enzyme glucose 6-phosphatase. The jittery spells this patient experiences is a classic symptom related to hypoglycemia. The patient is unable to maintain a fasted blood glucose because of the deficiency in the ability to adequately store glycogen. When epinephrine is administered under normal conditions, a patient's serum glucose should increase, and this is due to the hormone activating glycogenolysis in the liver and skeletal muscle, along with hepatic and adipose lipolysis and hepatic beta oxidation of fatty acids. With the inadequate storage of glycogen and therefore inadequate use of glycogen, when epinephrine is administered to this patient, an increase of blood lactate is observed. The inability to convert glucose 6-phosphate, or G6P, to glucose causes excess G6P to be shunted to alternative metabolic pathways, including lactate production. G6P, if shunted to glycolysis, will result in pyruvate and will either produce oxygen and carbon dioxide under aerobic conditions or lactate under anaerobic conditions. G6P could also be shunted to the pentose phosphate pathway. Either pathway, an increase in blood glucose would not be observed. Galactosemia, which was another disorder that this could have been, but I'm going to refute it here. Galactosemia is characterized by a complete lack of enzyme galactose 1-phosphate uridyl transferase, or GALT. This rare disease is caused by a mutation in the GALT gene. Galactose is readily converted to glucose in the liver through a reversible reaction utilizing GALT. Although at first look it appears this patient exhibits a few symptoms of this disease, such as hepatomegaly, diet of only breast milk, and hypoglycemia, there are a few signs that veer from this diagnosis. One would be the fact that this patient's blood glucose levels increase after breastfeeding, and with galactosemia, galactose is unable to be converted to glucose, so there wouldn't necessarily be an increase in serum glucose. The other clue would be the increase in blood lactate with the administration of epinephrine. Hereditary fructose intolerance is characterized as a deficiency in the enzyme aldolase B. Aldolase B is responsible for the metabolism of fructose and also functions in hepatic glycolysis by cleaving fructose 1,6-bisphosphate. Symptoms include nausea and vomiting after fructose ingestion, profound hypoglycemia, and hepatomegaly. These symptoms occur with the ingestion of fructose, which is found only in trace amounts of the breast milk, so it's not likely that this patient has this deficiency. Glucose 6-phosphate dehydrogenase deficiency is a genetic mutation that's nearly exclusive to males. Patient is female. The loss of this enzyme in red blood cells leads to a decrease in NADH production and decreases the lifespan of the cell, hemolytic anemia. This leads to paleness and jaundice of skin and eyes, or yellowing of skin and eyes, fatigue, and increased heart rate. This patient is not experiencing the symptoms, and therefore this diagnosis is ruled out. So the official diagnosis would be the glycogen storage disease. All right, and that's my video. Thank you for watching.